So I'm thrilled to be here with my friend and colleague, Dr. Ahmed, a genital urinary oncologist at Emory University with myself. And together, we recently published a review in ASCO Daily News on de-escalation strategies, specifically in de novo oligometastatic hormone-sensitive prostate cancer. So to start things off, before diving deep into the specifics, Dr. Ahmed, could you give us in the audience, a brief overview of our paper and why we felt this was an important topic worth highlighting today?
Thank you so much, Dr. Ciuro. It is my pleasure to be here with you talking about this. Doublet and triplet therapies are the standard of care now in patients with metastatic prostate cancer, and the standard is long-term treatments. I think it is important to kind of talk about when can we de-escalate treatments because these treatments do have side effects, which include cardiovascular side effects as well as overall deconditioning and quality of life issues. And so that's why I think we felt important to kind of talk about these issues.
Thank you for that overview. As you mentioned, our goal was to really identify, patients perhaps that we could actually undergo de-escalation strategies, and really highlight some of the, ongoing as well as past trial data looking at this question. Because like you mentioned, I really think that the goal for our patients is to not decrease efficacy, but also reduce the toxicity of long-term therapy. So it was great to, review the current data with you, and I'm excited to dive a little deeper. What we did find in one of the main key themes of our paper was actually that de-escalation strategies, definitely should be guided by clinical factors. You did mention, disease biology, metastatic burden, maybe molecular profile. But I guess, after looking at the data together, in your own clinical practice, what biomarkers or imaging findings, what do you find most influential in your approach in treatment de-escalation for these patients?
Yeah, I think in the absence of very hard evidence that, who are the patients who can be de-escalated, we have to be very careful about who, the patients that we are going to de-escalate with treatments. And so I think of it as both from a perspective of disease biology, in terms of patients who have more aggressive disease might not be appropriate for de-escalating. So that would include your Gleason score, the amount of metastatic disease that they might have, their PSA kinetics, how quickly they responded to the treatments, and have they had a sustained response to the treatments? And then also, how the patient factors, how are the patients doing? There are patients who are, on excellent exercise programs and are doing great, and would like to continue treatments because they have not had major side effects. And then on the flip side, there are definitely patients who are having quality of life issues. So I think it's a case by case discussion, but all of these factors kind of are taken into that. Another probably less evaluated thing is looking at genetics. So TP53, RB1, PTEN. Those are if you found those genetic mutations in their somatic testing, it might be appropriate to keep them on treatments longer, just because they might develop aggressive disease quickly sometimes.
I think that's a fantastic answer. You hit all the key points. I'm really just highlighting that it's a very, nuanced field. It's very complex. It's not really one treatment fits all. It definitely depends on the patient you have in hand. And I think in my own clinic, I think if a patient walked in my office with high risk features that you're describing, like visceral metastases, high volume disease, or some of these molecular markers that you highlighted, like PTEN, RB1 loss, et cetera, I think I have to be very cautious in pursuing these de-escalation treatments. And actually, I don't offer that unless, of course, a patient's having toxicity to therapy. So, I really think we have to take the patient at hand, the toxicity profile and what they want out of the quality of life. I'm kind of balancing toxicity and efficacy. So it's becoming a more complex field for sure.
Absolutely.
Yeah. And, is to pivot, part of our discussion in our paper together was looking at metastasis-directed therapy. Also, we refer to that as MDT. And that's really utilizing radiation with intermittent or short-term androgen deprivation therapy. And in the paper together, we did have a table really highlighting some of the past and ongoing trials to really look at MDT. But I am curious, at your institution or our institution, how do you really go about MDT, with the radiation oncologist? How does that influence your decision for de-escalation strategies? And what do you really talk to your patients about when they ask?
Yeah, I think it's an evolving role of MDT in metastatic prostate cancer, and we're learning a lot as we go. But in our practice, currently, what we're doing is we are all patients with low volume metastatic disease, they are getting radiation to the prostate as per Stampede. And
Yep.
for oligometastatic sites, we also do SBRT to those sites. So the idea is to encompass all visible disease on a PET PSMA and then target it with radiation, along with doing systemic treatment as much as the patient can tolerate. Sometimes we will do hormonal intensification for these patients as well. And then the goal is to reach 2 years of treatments, hopefully with an undetectable PSA that by that point that is sustained, and hopefully with no other evidence of progression during that time. And then at that point in time, I will usually offer de-escalation strategies. Sometimes patients are developing toxicities way earlier than the 2 year mark. And I think for those patients also, it would make sense to kind of stop the treatments and kind of study the PSA kinetics afterwards, especially if the PSA comes back fairly quickly and is rising quickly, then I think those are patients who may not benefit from de-escalation strategies, might need long-term treatments.
And I think that's a fantastic answer. I've used intermittent ADT with metastasis-directed therapy a few times in the office, but I definitely think it has to be a certain patient population as well as a discussion between the radiation oncologist, the medical oncologist, as well as the patient. Because when you're looking at the current NCCN guidelines, metastatic HSPC as a whole, it really highlights either doublet or triplet therapy. And, we do have ongoing trials evaluating de-escalation strategies, but I think it really depends on the patient at hand and having, their PSA kinetics. What is their PSA nadir? I think that's, we know from the recent ASCO update, that's also very important. Are they truly oligometastatic? So I completely agree with all of the above.